So first of all, we need to make sure that everybody's on the same page and that we all understand what a joint is. So simply put, a joint is where two bones come together. Now they can look pretty different. So you might have a wrist, you might have a hip joint, so you think of that fancy ball and socket. We know about ankles, and those tend to be what we call a saddle joint, where a bone sort of straddles another bone. We have knee joints that people are used to seeing, and that's the simplest thing, where two bones come together and they're held together by a bunch of stuff. But what you really need to know about the joint is goes a little bit deeper than that. And so I mentioned there are the two bones here, so this is my arrow just to show you where the two bones are coming together. And a lot of the action is going to have to do with where this sort of greenish, I guess, on that screen it's coming up as, and that's the cartilage. That is the shock absorber or the cushion that Mother Nature has put on the ends of bones, and to really help reduce how much pressure is felt on each of those bones when they go through the movement that they are meant to. These cushions, or cartilage, what we call cartilage, are made up of material when we are younger that loves to hang on to water. So it's a brand new sponge, and you can compress it down and then it comes right back up. And as it does that, it sucks up some of the pink stuff in there, which is called synovial fluid. And that's how that cartilage is nourished. It's a very unusual tissue that we have in our bodies because it does not have a blood supply. And it's really neat, and it can be compressed down like that all the time and repeatedly because it also doesn't have a nerve supply. That's going to become important when I start talking about when things go wrong, because it then starts to limit our ability in terms of what we're going to be able to do, the fact that there's no blood supply there. This pink fluid that is meant to nourish the cartilage is produced by this stuff from the deep pink, and that's called a synovial membrane. And normally that's really thin. It's sort of like the little skin between the layers of the onion, only about 2 to 3 cells thick, and it makes this fluid that helps to lubricate the joint so things don't get stuck together, but also to help nourish the cartilage. In some conditions, though, that can become a lot thicker. And then the whole thing here is surrounded by something called the joint capsule. That's the part that you see in black and gray there. Okay? Now, what about inflammation? What are we talking about when we use those terms? Inflammation is simply put when you have some increased activity of the immune system. And we normally know that that's taking place because oftentimes there will be a bit of swelling. There might be some redness, maybe some warmth of the area, and it might be painful. Now, most inflammation is not harmful. And in fact, most of the time when we have inflamed tissues, it's a good thing. So the last time you cut yourself and you had a nice deep cut, when that started to heal, the borders got kind of swollen and puffed up. They were red. Maybe there was even some stuff that seeped out of there. Hopefully it wasn't too creamy or white looking. It might have been clear. But those are all signs, and then it got itchy and was probably painful. Those are all signs of inflammation. And that is what normally has to happen when we heal tissues. The problem is when we start talking about inflammatory arthritis, what has happened is that that inflammation has become uncontrolled. And when the inflammation is uncontrolled, then it can start to damage tissues. And that's when things get out of hand. So in a joint, what the inflammation will look like, so on the left side, you have what that normal joint looks like. On the right-hand side, you have what it looks like in rheumatoid arthritis and other types of inflammatory arthritis. So what happens is this nice sort of dark orange colored here, that's nice and thin, that's the synovial membrane in the normal joint, becomes now really, really thick. So instead of being 2 to 3 cells thick, it's about 50 to 100 cells thick. And it makes a lot more fluid. So now the fluid, instead of there being just a little bit that's light orange, now it's a really dark color. There's a lot more of it, so it's stretching out the joint. And when we examine patients, that's going to feel squishy. It's going to feel like grapes between our fingers or water balloons because it's fluid in there. The problem is the fluid has changed. So when it was normal fluid, it's actually quite clear, and it's almost the consistency of honey. It's quite thick. In inflamed tissues, however, it becomes very cloudy because it's full of white blood cells that are the mediators of inflammation. And it also becomes really runny because it's full of this toxic stuff that can start to damage cartilage, that can damage the bone on either side that's not covered by cartilage. And you can see here, it doesn't take much of an imagination to see that if I'm stretching out the joint, I'm going to stretch out the joint capsule, and I might end up stretching some other things that sit out here, like tendons that help to hold, and ligaments that are holding part of the joint together. So that's going to contribute to some of the damage that we are worried of seeing in patients who have inflammatory arthritis. So that leads into what types of damage that we look for. So we look for a loss of cartilage. That we can see in patients who have degenerative arthritis or inflammatory arthritis. And in degenerative arthritis, that's really the main type of damage that we see. In inflammatory arthritis, like rheumatoid arthritis, we're also going to see damage to bone, both locally, right at the site where the inflammation is, but also in some conditions like rheumatoid arthritis, there can be bone loss throughout the entire skeleton. And we can also see the stretching of the cartilage as well as the ligaments. So this is what it starts to look like. And when you're in the business of rheumatology, you get used to looking at people's hands. And my daughter, who's sitting over there because it's Bring Your Kid to Work Day, so I made her come tonight, knows that when we go to the grocery store, I look at people's hands all the time. Anytime I'm holding somebody's hands at church, I'm always holding their hands and I never squeeze very hard. So you get used to looking for different things. If you look at these hands, certainly many of the joints look abnormal, but they look like if you tried to squeeze those, they would be hard, really hard like this. We call those almonds. And that's the sort of thing that we see in osteoarthritis or degenerative arthritis. Because what has happened is that the cartilage has gotten thinner. And as the cartilage has gotten thinner, the bones on either side of that joint, which are very well innervated, so they have plenty of nerves, they become very much more aware of the pressures now coming through that joint, they try to spread the pressure around, like we're all going to do in a couple of months when there's a bit of ice and it's not too thick. We're going to spread the weight around so that we don't fall through. This is the same thing that's going on, and there are bony enlargements that are causing this expansion in the sides of the joint, but it's not swelling because it's quite firm when you touch that. Compare that to the appearance of these joints here, which don't look normal either. But even in this picture, they look squishy. They look like you could squeeze that and it would be grape-like, and it would be kind of boggy feeling. That's what it feels like in patients who have inflammatory arthritis. So, why do people get arthritis? Well, if I had a great answer for that, I could probably retire. And there's a lot of different reasons that seem to contribute. And it depends a little bit about whether or not we're talking about inflammatory arthritis or whether we're talking about degenerative arthritis. When we're talking about degenerative arthritis or osteoarthritis, there's two principles at play. Either you've done something abnormal to a normal joint. Okay? We've just finished the World Series. Think of those poor pitchers who throw a baseball repeatedly at 100 miles an hour over and over and over again, hundreds of times a day. The human shoulder was not designed to do that. And consequently, all of those pitchers end up with significant osteoarthritis in their shoulders and potentially in their elbows as well, because those joints were not meant to perform that way. Whoops, sorry about that. That's very different than somebody who does normal activity on an abnormal joint. So if we think of somebody who's had an injury to a knee, somebody who perhaps tore a ligament playing hockey or football as an adolescent, and then continues with normal activity, but that joint now was allowed to go into movements and into positions it was never meant to. And over time, that causes damage to the joints. Other things can contribute to that as well. So sometimes if people are overweight or a lot of overuse, so some of the stuff that welders and plumbers have to do where they generate really high pressures with their hands when they're using wrenches, those sorts of things will contribute to osteoarthritis as well. But on the inflammatory arthritis side of things, the causes are quite different. Because on the inflammatory arthritis side of things, what's going on is that the immune system is misbehaving. Sometimes people think, oh, my immune system is overactive. That's not the problem, really. And so the best way I can liken it to is those people that you know who are really hyper. You know, they get up early in the morning, they stay up late at night, they're on 10 committees, they work full time, they have 5 kids who all get straight A's, and everything works really well, and you go, ugh. They have the best garden, they cook, you know, they make their own bread, you know, they probably have raised chickens and do everything else. Those people are hyper. That's not what the immune system is doing in inflammatory arthritis. In inflammatory arthritis, the immune system is hyperactive. So it's all over the place, and it's not getting a bunch of stuff that it should do properly, done properly. So patients who have inflammatory arthritis have increased rates of infection, and they have increased rates of cancers because the immune system is not controlling those things properly the way it should. Plus, the immune system is now getting into troubles that it shouldn't. So it's attacking the joints when it shouldn't be. And so when we start talking about treatments, we're not talking about just putting everything down. We're talking about trying to normalize the function. Now, in inflammatory arthritis, I've got smoking in the boldest letters here because, in fact, there is a growing body of evidence that suggests that people who have been ever smokers certainly are at increased risks of developing inflammatory arthritis and other types of autoimmune disease because the smoking acts as a chronic stimulus and a chronic irritant to the immune system, and eventually that means that the immune system will just misbehave altogether. We also know that smoking has a close link to periodontal disease. And that seems to come because it's a chronic sort of infection in the gums, and that periodontal disease then again acts as another irritant to the immune system on a repeated basis over a number of years. And over time, that increases the risk of people developing rheumatoid arthritis and other types of inflammatory arthritis. And there have been some studies that have looked at actually treating that periodontal disease. We know that at least half of our patients with rheumatoid arthritis have moderate to severe periodontitis at presentation. And if that's treated, many of them get better, and get better to the extent that some of our medications would make them better. So it's something that's important to think about and not to ignore. Genetics play an important role. Now, they play an important role, but they're not the only role. So if you have a first-degree relative, so a parent or a sibling who suffers from an inflammatory arthritis, your risk of developing a rheumatoid arthritis, for example, increases by about 3-fold. But in the general population, the risk is in Canada, the risk is about 1%. So that means that risk increases to about 3%. So it's not a huge increase. We know that certain populations are at higher risk of developing an inflammatory arthritis. So people who are Native Canadians are much more likely to develop an inflammatory arthritis than are the rest of the Canadian population. So genetics are playing some sort of component, probably playing some sort of component because of their interplay between the genetics and the infections and maybe the smoking, but it's not the primary driver. So you can have an identical twin who has lived slightly differently than you, who would not develop arthritis. So genetics aren't the only thing. We think that latitude is important. Notice I'm getting pretty far down here in my list and the print is getting smaller, and that's deliberate. And that's because we believe, we know from different types of autoimmune diseases that the more you move away from the equator, the higher the rates of autoimmune disease. And that's not just inflammatory arthritis like rheumatoid arthritis, but includes other types of autoimmune diseases like type 1 diabetes, like multiple sclerosis. And we think that somehow the link there relates to vitamin D exposure, because that's what happens as you move away from the equator, north or south, you get less and less sunlight exposure, and therefore your vitamin Ds tend to run a little lower. With that said, in arthritis, by the time patients develop their disease, just replacing vitamin D isn't going to be enough to turn off the immune system. It's important, and some studies would suggest that it certainly helps prevent some of the joint damage that we see, but it's not enough to shut down the inflammation once it's gotten going. And then nutrition. We know that obesity also serves as a chronic inflammatory stimulus, so we want all of our patients to have a healthy nutrition. But I'm often asked, should I be avoiding nightshade vegetables? Should I avoid citrus? And there are no good peer-reviewed publications for me to tell patients that you should avoid this or you should be eating that. I can tell you that there have been a couple of very small studies that have looked at the influence of a vegan diet. That means a total elimination of all animal protein. And there was a slight benefit in patients who had inflammatory arthritis, but that benefit was in the range of about the equivalent of taking ibuprofen at 1,200 milligrams a day. So for some people, that's what they choose to do, and they can sustain themselves very well, though you need to be careful to get enough protein. But for most people, that kind of strict diet simply isn't feasible. And I wouldn't encourage everybody to do that because the benefits are so limited, and I don't think that in most people it's worth the inconvenience and the cost and the potential side effects of the nutritional deficiencies of that kind of extreme diet. There's also some studies that suggest that making sure that you get enough fish oil, so in the range of 2,000 to 3,000 milligrams per day, that actually may have an anti-inflammatory benefit. And that's actually a little bit more promising. Although for most people that means they're going to need to take supplements because it's hard to get that just from very oily fish. And not everybody likes it because it does tend to kind of repeat on you, and you have to be really fond of fish if you don't mind that kind of repeat. So how do we make the diagnosis? Well, in my practice, we actually talk to patients. That's what rheumatologists do. We sit down and we talk to people for a fair bit of time, and then we examine them. Then we order blood tests, and yes, in rheumatology we are very fond of our blood tests, so there's usually probably 3 more tubes, depending on what we're looking for and what we've ordered. And then maybe we order some x-rays, because we're going to look for particular sorts of damage. When we talk to the patients, what we want to know from them is what are the sorts of things that make their pain better and what makes it worse. So patients who have degenerative arthritis are usually going to have pains that get worse as the day goes on, and that gets worse the more they use the joint, because it's a joint that's kind of worn out, that doesn't have the cartilage that it's used to. Patients who have inflammatory arthritis are oftentimes going to have a lot of stiffness in the mornings. They have to get out of bed, they have to move because they get too stiff. They'll oftentimes describe swelling, and their pain may in fact get quite a bit better if they can, once they get going in the morning and they've done a bit of exercise, they'll find that they get better after an hour or so, and they're okay again until the very end of the day. So those are the sorts of things we like to talk about when we're talking to our patients. When we examine them, I already told you we're feeling for almonds and grapes. So does the patient feel really hard? Do those joints feel really firm? Do they kind of stop moving at any given point? Or do they feel really squishy between my fingers? Because that's going to lead me one way or another. And all of this really is just a bunch of signs that we use to point us in the right direction, right? And so my husband knows this very well. And that none of these things are in and of themselves diagnostic. So sometimes I see patients who've been referred to me because their blood test said they had rheumatoid arthritis. Sometimes the patients think, well, my blood test said I had lupus. My doctor says my blood test. But there is no one blood test that will make a diagnosis. We are looking at a collection of things to put together that point us in one direction or another. So these are some of the x-rays we're going to look at. And I think we're going to drop the lighting just so you can see these a little bit better. So these are some of the things I showed you some pictures before of what joints look like. This is the sort of thing that we look for on x-ray. So this is an x-ray of a person who has osteoarthritis or degenerative arthritis. And what you can see is that you have to take my word for it, but the bones here actually look quite normal. So they look pretty white, okay. The wrist here looks really good. These joints in here, which are these joints here, those look pretty normal. And the action comes when we come out to these joints or to these joints on the ends. And then you start to see that things look pretty abnormal. And you can see here where you can see a nice space between joints. Over here it gets harder to see the space between the two bones. Similarly, here you can kind of see a nice space. But if you look in here, you don't see a space between the two bones very well anymore. And that's the kind of thing that we see in osteoarthritis. And we see that the joint space is very irregular. Compare this to this patient. So this is clearly a very different problem. Remember, just to show you what a normal wrist looks like, here's this person's wrist, okay? There are supposed to be 8 little bones in these wrists that you should see. But they kind of look like they've gone to mush and they've all collapsed together. First, that kind of involvement at the wrist level is what we expect is what we can see in rheumatoid arthritis. I don't want to use the word expect because I don't expect to see it with appropriate treatment anymore, okay? But you can also see here that in addition to the wrists being involved, these knuckles in here don't look quite right. These knuckles in here certainly don't look quite right, and things are going off in really funny directions. This hand, the person couldn't even open it to be able to put it onto the x-ray plate. That's why it looks like that. So this is what we see in rheumatoid arthritis. And the other thing you can see here is compared to these bones, which I said were quite white, these ones almost look like they've been washed out. You can see through them. And that's what happens in rheumatoid arthritis as well, where the entire skeleton becomes thinner and becomes osteoporotic. So that means thinning of bones. This is what hips look like. This is a person with osteoarthritis. So you can see here, this is the good side on the left side, which isn't ideal either, but you can see a little bit of space between these bones here. Not a lot of space down in this part, but then you come over and compare it to the right side, and you can't see a whole lot of space between this ball here and where the socket is. So it's hard to imagine how that ball is going to be able to move inside of there, and that person's going to have a fair bit of pain. These are the knees of somebody with osteoarthritis. So again here, the outside bit doesn't look too bad. That's the outside part of the knee on both sides here. You can see a bit of space. But again here, we don't see cartilage on x-rays. We make an assumption about what's happened to it because we don't see it anymore, and the two bones are abutting each other at the knees. So again, that's going to grind a fair bit when this person tries to walk around on that. These are working our way down. We're down to the feet. And again here, it looks like something's been taking little bites out of little bits of all of these bones here. This is what we see with rheumatoid arthritis. We call those erosions, all of those little bites. And those are the things that we're looking for on X-ray that we're really hoping, that we're trying to prevent. Okay, so the treatment options for inflammatory arthritis and for rheumatoid arthritis both kind of go around this wheel, but they go around this wheel or this circle in a slightly different way. So our exercise and physiotherapy are important for both osteoarthritis and for an inflammatory arthritis. In osteoarthritis, it's important because those patients oftentimes have more issues with weight, and the exercise is going to be important in terms of weight management. But it's also important because I didn't talk about the fact when I showed you the pictures of the joints, what I didn't have there were the muscles. And we have muscles that cross every single one of our joints. And we think of those muscles in terms of the role that they play in allowing us to move. But those muscles are also really important because they cross the joint. And because they cross the joint, they help to offload it. And if the muscles get weak, all of the pressure comes down through those bones and through that joint and through where the cartilage ought to be. If the muscles are strong, that actually takes some of the stress off of the joint and off of that cartilage or what's left of it. So in fact, muscle strengthening can be very important, particularly when we talk about patients with knee complaints and knee pains. It's also important in terms of exercise, in terms of maintaining range of motion in patients who have osteoarthritis, because those patients, sometimes if you can't move something, if your hip is really bad and you can't move it, then you move less and less and you're going to tend to do this sort of thing. The problem is then if a surgeon goes in and tries to fix that for you, if you have spent the last 2 years standing like this, it's going to be really hard to stretch that back up, and that puts a lot of strain on some of the other joints. So that's the role that exercise and physiotherapy can play there. On the rheumatoid arthritis or the inflammatory arthritis side, the exercise is important because patients tend to lose muscle mass. Having that kind of steady inflammation, if it's not well controlled, actually can eat away at the muscles. So the muscle mass actually tends to drop on its own. And that can contribute to other problems like an increased risk of developing diabetes or an increased risk of heart disease. So maintaining the muscle mass helps to reduce that. The other thing is that if a joint has gotten really badly swollen at one point, and that means that some of the ligaments got stretched, even if we take the swelling away, now things are going to have some extra play because everything that was supporting it is really, really loose. So having the muscles maintain strength around the joint will help protect the joint when we take the swelling away. What about managing pain and stress? We know that that's important because patients who have pain on a daily basis oftentimes get into a very bad place. And we see that sometimes in the office where patients have pain every single day and then they get a bit depressed and they don't manage their stress as well. And then that actually contributes to their ability to manage pain dropping down a little bit. So then the pain that they had is that much worse. And that makes their stress worse. And then it just sort of keeps spiraling down that way. So we know that patients who have chronic diseases, we know that patients who have chronic pain, that those all have a significant emotional impact because it plays on, how people feel about themselves. It plays on how people are able to do the things that they thought were important. And it's important that that not be ignored and that that be addressed because otherwise it will contribute to making symptoms worse. And so and we don't necessarily want to have to medicate that. Lifestyle choices are important, and I mentioned that. I mentioned the issue around weight management. The other issue is smoking can be really important. Smoking plays a significant role in terms of potentially increasing the risk for autoimmune diseases. But the other thing is, in those patients with rheumatoid arthritis who smoke, we know that they don't respond nearly as well to medications. Certain medications used by themselves won't work. We'll now have to start using combinations. And certain combinations that normally would be effective in 60 to 75% of the patients are now going to be effective in maybe 45% of the patients. So that can be an important adjunct to therapy. Managing fatigue is important. We all know if we haven't had a good night's sleep or if we've had a long run of not sleeping well, then nothing looks good the next morning. So that's important to manage. It's important to protect the joints. So if you have, for people who have significant knee osteoarthritis with weakness of the muscles on the front of their thighs, if they're tending to hyperextend their knee a great deal, maybe there's a role for a knee brace there to prevent them from getting into a position that risks damaging their joint further. So those can be important. And then finally, we can get to medications, and we can talk about the role of medications in managing osteoarthritis or inflammatory arthritis. And really, the treatment options here are going to vary depending on whether we're talking about an inflammatory arthritis or whether we're talking about degenerative arthritis. So in osteoarthritis, we have a very limited goal, and that goal is pain management. We do not have any medications in 2015 that will change the course of disease in osteoarthritis. Okay, I look forward to the day when I can stand here and tell you we do, but right now we do not. And so our goals when we start talking about using medications in osteoarthritis are to manage pain. So we're going to start with non-medication things first. We're going to talk about the exercise. We're going to talk about muscle strengthening. Medications can play a role. And then because this is potentially a chronic disease that we don't have a cure for, we're going to start with the least toxic medications. So we end up talking with acetaminophen or Tylenol. If that doesn't work, then we can work the way up to using non-steroidal anti-inflammatories in some patients. In some cases, injections of cortisone or something to what we call viscose supplements can be helpful. And that can, excuse me. Okay. Viscose supplements can oftentimes also help to kind of grease and lubricate the joint a little bit. Sometimes, though, patients will need more potent pain medications, and family physicians are usually the most appropriate place to go to pursue those. Sometimes as well we'll use what we call co-analgesics. So medications that are not painkillers in their own right, but that if they help to manage nerve impulses or if they help to improve sleep, can also help to manage pain. And lastly, sometimes we'll refer our patients for surgery. So this is a patient from earlier who had the really bad hip, and this is what it looks like after the surgeons have gone in and replaced that hip. And that moves a whole lot better. This is a very successful surgery. About 85 to 90% of patients, if you ask them 12 to 24 months later, are extremely happy with the result of this procedure. This is what a knee replacement looks like. So this is the knee and the left-hand side before the surgery. This is the knee right after surgery. So those funny little ladder things that you see coming down, those are the skin staples that are closing the incisions. This surgery, again, is also quite successful, although only about, not quite as good as a hip replacement. So 70 to 75% of people are happy at the 12 and 24 month mark. It does tend to be a bit longer in the rehabilitation than the hip surgery is. And some people aren't so happy because they don't always get the bend in their knee that they wanted to get back. So what about inflammatory arthritis? Here you can see already that the goals look different. I have included reduction of pain there, And it comes in at number 3, not because I'm a sadist, but because we need to get that inflammation under control. I talked earlier about the person who was hyper versus the person who was hyperactive. I would not treat the person who was hyperactive with a tranquilizer just to bring them down. I want to be able to use a medication that gets them to do what they need to accomplish well, properly, and to get them to stop doing what they don't need to be doing. And that's what I want to do. Those are the goals of treatment in inflammatory arthritis. We want to take away the swelling and the inflammation that doesn't belong there. We want to prevent the joint damage. So I showed you the x-rays of the hands and the feet. We want to prevent that, and we have medications that will prevent that. If we do those things, then we will reduce and eliminate the pain that the patients have. And we also want to reduce the non-articular complications of inflammatory arthritis. So what are those? So the complications of the disease that are not related to the joints. So we know that patients with inflammatory arthritis sometimes can also get inflammation of their eyes. Sometimes they can get inflammation in their lungs or the lining of their lungs. We know that they have an increased risk of infection. We know that there's an increased risk of certain types of cancers, in particular lymphoma, and certain types of lung cancer. And we also know that our patients are at increased risk for heart disease. So inflammatory arthritis is as important a risk factor for heart disease as diabetes is. So we need to manage that. We want to normalize those risks. We don't just want to take the patient's pain away and leave them at increased risks for cancers and infections and heart disease. And so we use medications that target the immune system to get it to behave the way it should. So this is what the immune system looks like, right? That's what you're ready for. And we have a whole bunch of targets that we can use now. We certainly have medications that will target the whole thing, okay? So if you bear with me for a second here, I'm going to try to give you the very simplified version of where the immune system goes wrong in rheumatoid arthritis. So you have these APCs, which stand for antigen-presenting cells. And antigen-presenting cells have as their job to roam around your body and look for things that don't look right. And then they're supposed to munch them up and present them to the rest of the immune system, to the rest of the soldiers. So they're on a constant recce, right? They're just going out, they're looking for anything that looks kind of wrong, and then they bring it in, and they say, look at this, what do you think? Do we like this guy? Do we not like this guy? Are we letting him in? Are we going to get rid of him? What do we do? It brings them along to these T cells. So T's and B cells are other types of white blood cells, and the T cells take a look at this thing that the antigen-presenting cell brought in and make a decision. Do I like it? Do I not like it? If they decide they don't like it, they're going to talk to the B cell, and they're going to dispatch those B cells to make antibodies, right? You've heard about antibodies, because antibodies are things that are proteins that we make that can go out and stick to bacteria and to viruses and prevent them from making us sick. When we go for our flu shots, the purpose of that flu shot is to make antibodies that will stick to the influenza virus if we are exposed to it. Now, those antibodies, if they get made, and in rheumatoid arthritis, sometimes they stick together and they make great big clumps. That's what we call rheumatoid factors. Those then can stimulate directly other white blood cells. These T cells can also make chemicals that will stimulate other types of cells that are the foot soldiers and can go in and stimulate things in the joints and in the bone and in cartilage, and that could cause a lot of damage. So we can use medications that will shut all of that down. The problem is some of that we want. We kind of still want to be able to make antibodies, right? There's only some antibodies we don't want. We want the ones against the flu. We want the ones against pneumonia and some of the other things we can get. We want some of the T cells to still work. So as we get more sophisticated, we can now start talking about interfering with interactions between these two cells and limiting how they talk to each other. Or we can come in here and we can interfere with some of these really toxic mediators like tumor necrosis factor or interleukin-1. Or we can talk about, it's not in here, but interleukin-6 is also a nasty mediator. So some of the newer medications that you might see advertised on American television are really targeting very specifically certain chemicals that are important in the propagation of the inflammatory cascade. If we look at medications to treat inflammatory arthritis as a whole, they don't come without a cost, and other than the financial one, the other important costs are some of the side effects. In general, things like blood pressure and kidney can be an issue, particularly when we talk about non-steroidal anti-inflammatories, things like the Advils and the Aleve. Some of the other medications we use can sometimes suppress the bone marrow a little bit, so cause decreases in white blood cells, or red blood cells, or hemoglobin. Sometimes as well, some of our medications will irritate the liver, and so we need to keep a close eye on that. Some of our medications, unfortunately, can increase the risk of infection, in particular certain types of bacterial infections, particularly skin infections or sinus and lung infections. Sometimes they can increase the risk of developing shingles or sometimes increase the risk of developing tuberculosis. And there have been some concerns that some of our medications, particularly the newer ones, might be associated with an increased risk of malignancy or certain types of cancers. And that's particularly true with certain types of skin cancers that are more likely to occur in patients on these medications, so we monitor for that. So I want to leave a lot of time for questions, so I'm going to stop here. And so there's, the news in arthritis is a bit good, bad, and ugly. The good is that, we do have treatments in inflammatory arthritis that will help prevent joint damage and that are effective in at least 80%, up to 90% of our patients. We do know that to get most of our patients in remission in inflammatory arthritis, which is now our goal, is in fact many of those medications, the limiting step is going to be the cost, and some of those medications can run up to $20,000 a year. Although, even in New Brunswick now, most patients should have access to the financial support that they need to get those medications covered if they need them. Some of the bad is that there are no effective preventative therapies in osteoarthritis, and we know medications that are going to prevent the progression of the course of the disease. And of course, the really ugly is that we don't have a cure yet. But thank you very much for your attention. Yeah. Yeah.
Degenerative disc, how does that connect with?
So degenerative disc, the question is, where does degenerative disc disease fit in here? So degenerative disc disease really talks about thinning of the disc, which is a specialized sort of cartilage that sits between the vertebral bodies, and how that becomes drier, a little bit like the cartilage that we see in any other joint, and that becomes thinner, and as a result, it no longer acts as the shock absorber between the vertebral bodies. And so that's what we see when we look at the X-ray. We see that the space between the vertebral bodies has become much narrower. The challenge in patients who have back symptoms in general, when we're talking about degenerative symptoms, whether it's degenerative disc disease or osteoarthritis, is that there is essentially no correlation between what a patient feels and what their X-ray looks like. So I have patients who have horrific looking X-rays. I wouldn't want that X-ray. I'm glad that's not my back. But they actually don't have any symptoms. And I have people whose X-rays look really, really good, who really struggle to function because they have a lot of discomfort if they stand for too long, or they walk for too long, or they sit for too long, or they do any sort of twisting or lifting. And so the management there, the really important piece, is going to be the exercise and physiotherapy to strengthen up the muscles that support the spinal column on either side, because that's what's going to help to offload whatever's going on because of the narrowing of the discs.
Medications, I've heard about glucosamine, and I've heard glucosamine and chondroitin. Are they effective, or
Okay.
we're not going to make it better?
Right.
Is it?
So the question here is, are glucosamine and chondroitin going to make a difference? I have not seen any studies that have looked at using glucosamine and chondroitin in patients who have degenerative disc disease. Glucosamine and chondroitin have been looked at either alone or in combination for patients who have osteoarthritis. And there have been a lot of small studies done by various companies that make glucosamine and or chondroitin that have suggested that there's some benefit. There was a really large trial that was funded in Europe by one of the companies that made glucosamine and chondroitin, and it suggested that there was some benefit in the patients who took it. There was another large study funded by the National Institute of Health, or NIH, in the US. So they don't make glucosamine, they don't have any proprietary interest, and they were not able to demonstrate that it had any effect on patients' symptoms. So what I generally tell patients is there are some studies that suggest that this may be helpful. If you wish to try it, probably the weight of the evidence suggests that you should use it in combination and give it 8 to 12 weeks. If it helps, great. And if it doesn't, move on. Don't spend any more money. So this lady in purple and then that woman in the back.
So possibilities, but benefits there.
Sure. So in some patients who have osteoarthritis, they get a lot of involvement at the base of the thumb, okay? And before I proceed any further, just so the question was, what about the benefit with regards to surgery for osteoarthritis at the base of the thumb, sort of near the wrist joint area? And what benefits might be gained and what does that look like? And just please remember that when I answer this, you're getting a non-surgeon's opinion of a surgery, which tends to, in my world, our first rule is first do no harm, and our rule number 2 is keep the patient away from the surgeon, although they do some very good work sometimes, okay? So just so we're clear, I'm not here to do any surgeon bashing. Patients who have a lot of joint space narrowing, so really a loss of cartilage at the base of the thumb, it can be debilitating because you can't make a fist, you can't pull anything up. I mean, those darn thumbs, we use them for everything. Even trying to get your pants together to get the zipper up, counting your change, being able to pick any of that up, that's all going to aggravate the base of the thumb. The surgery in experienced hands, I think, is extremely successful. The patients I have sent to surgery and who have it done by people who do a fair bit of it have done very, very well. The rehabilitation tends to be a little long because in order to get that fine manipulation to regain the strength that we want and that we expect from our thumbs, that takes a while. But I have never had anybody come back to me and say that they weren't happy that they'd had it done. And it tends to be something that I particularly encourage patients to go for because the waits can be fairly long. These are done by hand surgeons or plastic surgeons. The waits can sometimes be long to get to surgery, and then the rehabilitation can be so long. But if patients are having a lot of discomfort in that area and they're under the age of 70, I tend to encourage them to get it done sooner rather than later. Once patients get over 75, you start to think, well, if they're going to be incapacitated for a year, can we manage them with splinting instead? And will that allow them to do enough of what they want to do without having to have them with a gimpy hand for a year? So that tends to sort of be where I tend to lead my patients, but there's no right or wrong answer there. Okay. So the question here is, I mentioned about exercise a fair bit. What about the kinds of foods that you shouldn't touch? So I alluded to the fact in my presentation that there's not a lot of evidence when it comes to, there's not a lot of good quality studies that have been done with regards to nutrition and osteoarthritis or inflammatory arthritis. So the only, the best study that's been done in inflammatory arthritis looked at taking away all animal protein, and the benefits there were really very limited. Some patients clearly come in and tell me, if I eat peppers, my joints hurt more. Okay, you eat peppers, your joints hurt more, then don't eat them. I'm not going to dispute that with any patient. But I have no scientific evidence to support that, to suggest to people carte blanche that you should all eliminate everything from the nightshade family. I don't have any evidence to support that. I don't have any evidence to support that everybody should take wheat out of their diet or sugar out of their diet, that it's going to make a difference to your symptoms. It may, and it may simply help with weight management, and then that'll be helpful.
But we can hear so many stories, we don't even know what to do with.
Well, I think in those circumstances, that's where, programs, the arthritis self-management program that used to be fantastic in terms of helping patients, get their own symptoms under control.
We're not going to give it to anybody. This is why I feel it's so bad for us to be treated and ignored when we go into a doctor's office.
But I think, I'm not sure if you've ever explored with the Arthritis Society either the self-management program that they used to run or now, or their chronic pain management workshops. I think it sounds like you might do really well with that. So perhaps Krista could get you in touch with that.
Normal
Okay.
or?
So the question is around methotrexate, which, and in the treatment of an inflammatory arthritis, and how much you can take. So methotrexate we have been using since the early 1970s to treat rheumatoid arthritis and other types of inflammatory arthritis. And in the last 15 years, it has become the cornerstone, or 15 to 20 years, it's really become the cornerstone of management of inflammatory arthritis. It is the gold standard against which everything else is compared. We know from studies of patients, particularly in Boston through Brigham and Women's Hospital, they have a cohort of patients who've been taking methotrexate for 20 to 30 years. So is there a limit to how long you can take it for? No, not necessarily. If you're having routine blood work and everything looks okay, we now have new tools available to us. So for patients who've been on methotrexate, you may know that, though we monitor for liver function to make sure it's not getting irritated, for years the recommendations were that if patients had been taking it for a while, we would still refer you to one of our liver specialist colleagues who might do a biopsy. We don't need to do that anymore. Many of our patients now can simply go for a specialized type of ultrasound, and that will allow us to make a check in patients who've been on methotrexate for a really long time to make sure that it's safe to continue. In terms of how much of the medication we use, usually we max out at 25 milligrams per week, which would be 10 of the 2.5 milligram tablets, or sometimes we'll switch to the injection. If that isn't working to manage our patient's symptoms, then we'll oftentimes add something else in combination or move to something else.
Is prednisone in that same area as well?
So prednisone works as an anti-inflammatory because it shuts everything down. So it's the tranquilizer. It shuts everything down. The problem with prednisone, and if you're to any patient who has ever had a bad flare of anything inflammatory, prednisone is a miracle. It shuts things down so quickly. The problem is that in the long term, prednisone has too many side effects, right? We start talking in long-term use about weight gain, about cataracts, about hair loss or funny hair growth in women, about high blood pressure, about high cholesterol, about thinning bones, increased risk of diabetes, and increased risk of infection, and increased overall risk of death. And when we look at chronic use of prednisone in our populations, the risk of the increased mortality is 4% per milligram. So patients say, but I'm only taking 5 milligrams. It's only a 20% increase in mortality. Okay? I don't like prednisone for my patients in the long term. We sometimes get backed into a corner because nothing else is working, but I try really hard with my patients to find a better solution for them because a 20% increase in mortality is too high.
So what do you suggest in lieu of prednisone?
That's hard for me to sort of answer for you, to give you a specific answer, because that's really a discussion you need to have with whoever's prescribing the prednisone and the methotrexate in terms of what else might be used in combination. I mentioned we oftentimes move to combinations of medications, methotrexate with something called hydroxychloroquine, methotrexate sometimes with hydroxychloroquine and something else called sulfasalazine. If those don't work, we sometimes add something else called leflunomide, and if that doesn't work, then we move to the big guns, these new biologic agents. So we have sort of a breadth of things that we can choose from, and we tailor that to each patient. So the question regards to using over-the-counter topical anti-inflammatories like the Voltaren or the diclofenac ointment. And I think in patients who have very local, so perhaps one joint that's affected, particularly when they're quite superficial joints, like some of the hand joints, sometimes the elbows or the wrists, I think those topical anti-inflammatories can be very effective without carrying the extra side effects of putting blood pressures up and increasing the risk for stomach ulcers or damaging kidneys. So I think they have a great role. There's a lot of research being done. I have not heard of anything that's on the near horizon. And by near horizon, I mean anything in the next 10 years. So any trials that are being done are in the very preliminary stages. And we've had fantastic successes in rheumatology in the last 20 years in terms of what we now have available for patients that wasn't there before. We've also had some real disasters in terms of things going really off the rails. So they looked really good on paper, they looked really good in the lab, and then we gave them to patients and things went really, really wrong. So I think we're still quite a ways from me even be able to say, I see something. We're not there. Okay. So the question has to do with trigger fingers, which in fact is not a joint problem. Okay? So trigger fingers occur because we have a whole lot of stuff that goes on in our palms. In order for us to be able to do this, we have tendons that will pull our fingers in. But for the tendons not to get hung up on the nerves and the blood vessels and all the other stuff that's in our palms, those tendons have been given their own special highway, and that's called a flexor tendon sheath. Okay? In some people who don't have any inflammatory arthritis, who just use their hands a great deal, they can actually get some scarring along that tendon sheath. Some people, though, with inflammatory arthritis can also get some swelling along the tendon sheath. And what happens is that when you then start to use the hand, the tendon gets stuck in its highway. Kind of like if you had to pull a drawstring through something and you put the safety pin on the end and then you pull it through and you get it part way across and you get stuck and then you just give it a really good yank and then you can keep going. That's exactly what's happening in that with your tendon in a trigger finger. So that's why sometimes we can treat those with just a cortisone injection along the tendon sheath. If that doesn't work or if it keeps coming back, then we let our plastic surgery colleagues just open up the sheath a little bit so that the tendon can run through without getting hung up. So it's not a joint problem. How often would we give cortisone treatments? You mean by injections? That depends what I'm treating. So if I am treating a patient who has a recurrent swelling of a joint relating to an inflammatory arthritis, and all the other joints look great, but that one joint just doesn't want to settle down, I don't have a problem injecting that as many times as it needs to be injected. However, if I'm injecting cortisone because a patient has osteoarthritis, then I become concerned about the possibility that I might damage what cartilage is there, and that might contribute to actually accelerating the osteoarthritis, in which case I'm going to be leery about doing that more than a couple of times a year. But in inflammatory arthritis, because there's that toxic soup of chemicals in that swelling, that is going to cause more damage to cartilage than me injecting cortisone. And so it's worthwhile me just going in there and trying to get that to settle down. So it depends why I'm injecting.
Why can't we get more specialists in our area?
So why can't we get more specialists in our area? Well, I can tell you, I was in Ottawa last week because I'm an examiner with the Royal College for Rheumatologists. This year, there were 29 candidates for adult rheumatology across the country. We're not making very many, so it's very hard to recruit a whole bunch of people. That's why. Thank you, Sharon. That wasn't loaded at all.
Always on their mind.
Right. So the question is, from my dear friend, Ms. Steves, when should a patient expect to be referred to a rheumatologist? So, first of all, if a patient has swollen joints, if they have several swollen, squishy, boggy, grape-like, water balloon-like joints, they should be referred by their family physician to a rheumatologist as soon as possible. Our guidelines in Canada are very clear. The guidelines in the US are similar. The guidelines across Europe are similar. We would like to see these patients and get them started on treatment within 6 months of the start of their symptoms. And the reason for that is because when the immune system starts to go off the rails, we may have a sweet spot where we can get in there very early on and actually kind of curtail the momentum of that misbehavior and be able to redirect it, which might mean that wouldn't be exactly a cure, but it might mean that we can treat people aggressively early on and be able to then take medications away. So they might not be committed to lifelong multiple drug therapy for their inflammatory arthritis. That is what we would hope to do. And in order to be able to do that, we need to see the patients before this has been going on for too long. So lots of joint swelling, refer as soon as possible. In patients with osteoarthritis, the involvement of the rheumatologist then becomes a little bit different, because I would argue that most of what we would offer to the patient could be offered by the family physician in terms of referring them for exercise or appropriate lifestyle changes or physiotherapy or managing medications. Sometimes our role then there becomes more about reinforcing what a family physician may have already suggested, or in some cases, nudging the family physician in a particular direction to remember that there's other things to be considered, like using canes or splints or physiotherapy or occupational therapy when there's a lot of hand involvement. So that one, I think, is a little bit harder. In patients who are not managing, maybe it's worth a review with a rheumatologist, so a second pair of eyes to see what else needs doing. Sometimes there's some reluctance as well to refer patients for surgery. And it's very difficult. I talked earlier about the fact that I'm not a surgeon, and usually in my business we want to keep the patient away from the surgeon. But hip and knee replacements are really good procedures. And I think for overall, we tend to wait too long for the patients to get to the surgery, and they tend to be incredibly out of shape by the time they get there, which makes their rehabilitation much more complicated. And so if a visit to a rheumatologist is going to help push that in the right direction, I think that sooner rather than later would be better. Although in most rheumatologists' office, patients are going to wait longer to get in, because we are desperately trying to get those inflammatory arthritis patients in sooner, because we have more to offer them, and because they have these whole other, we're not just treating their joints, we're treating the whole rest of them and all of the increased complications with regards to the cardiovascular disease. So we're trying to get those people in first. So the osteoarthritis come in second.